evening, everyone, and welcome to the DeVos Medical Ethics Colloquy. My name is Dr. Lola Koch, and I serve as the Director of Strategic Initiatives in the Kirchhoff College of Nursing at Grand Valley State University. Our college, along with the College of Health Professions and the College of Liberal Arts and Sciences, now serve as your GVSU hosts of this biannual DeVos Medical Ethics Colloquy. The topics covered in these important dialogues directly impact our interprofessional healthcare providers, those who are still students, and those who are actively serving in our community. We are pleased to provide the platform to continue this prestigious event and to join in these discussions. More information about tonight's event, including information on claiming continuing education credits, can be found on our event welcome website, gvsu.edu/colloquy/welcome. A special thanks this evening to our Colloquy Planning Committee for their ongoing support and leadership of this DeVos Medical Ethics Colloquy. We would also like to recognize our principal sponsors, Grand Valley State University and Spectrum Health, and our major sponsor, Trinity Health. And now I'd like to begin by introducing the deans of the supporting colleges. First, Dr. Catherine Moran.
Thank you, Dr. Koch. I am honored to participate in this prestigious event.
Thanks, Dr. Moran. Dr. Jackie Zhang from the College of Health Professions.
Good evening, everyone. Welcome.
And lastly, Dr. Jennifer Drake, the Dean of the College of Liberal Arts and Sciences.
Thanks, Dr. Koch. Happy to be here and welcome everyone.
Thank you all. So again, I'd like to thank the deans for their support of this event. Now, to give our opening remarks, I would like to introduce Dr. Paul Farr. Dr. Farr has been with the Colloquy nearly since its inception. He serves on our DeVos Colloquy Advisory Board, and he's our secretary. Dr. Farr.
Dr. Koch, thank you very much. It's an honor to be here tonight for the 35th biannual colloquy. Colloquy is a discussion, and the discussion was thought of by Rich DeVos, who's sitting down in this picture, and implemented by the man standing, Luis Tomatis. We lost Rich DeVos in 2018, and we lost Dr. Tomatis in 2020. We all miss them both to this day. I want to thank the Colloquy committee members and Grand Valley State University, but especially Dr. Lola Koch and Dr. Jeffrey Burns for their leadership. Without them, it's hard to see that this would continue. But we want to continue it because it's something for all health professionals and especially health professional students. So thank you and welcome tonight.
Good evening, everyone. I, like you, am very, very excited to hear tonight's excellent presentations. It's now my distinct honor and my privilege to introduce tonight's speakers. Our first speaker tonight will be Dr. Doug Diekema. Dr. Diekema is an attending physician and director of education for the Truman Katz Center for Pediatric Bioethics at the Seattle Children's Hospital and professor in the Department of Pediatrics at the University of Washington School of Medicine. He is board certified in both general pediatrics and in pediatric emergency medicine by the American Board of Pediatrics. He serves on the Committee for Bioethics of the American Academy of Pediatrics, and his research interests include pediatric bioethics and pediatric wilderness medicine. Dr. Diekema is also the author of Clinical Ethics in Pediatrics, a case-based textbook. Welcome tonight to Dr. Doug Diekema. Our second speaker later this evening will be Dr. Dominic Sisti. Dr. Sisti is the director of the Scattergood Program for the Applied Ethics of Behavioral Healthcare and associate professor in the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He holds secondary appointments in the Department of Psychiatry, where he directs the ethics curriculum in their residency programs, and in the Department of Philosophy. Dr. Sisti's research examines the ethics of mental health care services and policies, including long-term psychiatric care for individuals with serious mental health and ethical challenges in the correctional mental health care system. He also studies how mental disorders are defined and categorized with a focus on personality disorders. He is the co-editor of the book, Applied Ethics in Mental Health Care. Welcome also to Dr. Dominic Sisti. We will begin this evening with our first speaker, Dr. Diekema. Doug, take it away.
Thank you, Dr. Fauner. Thanks for that kind introduction. It's my great pleasure to be asked to speak today and be part of this, what's become a long history of wonderful colloquies. Our topic today is decision-making on behalf of children and adolescents. And my task, the path I'm going to take you on, is to initially talk about parental decision-making authority, follow that with a discussion of what the limits of that decision-making authority might be, and then finally explore the role of adolescence in that decision-making process. I like to start all of my talks with a case, and that is to center this in sort of the clinical environment, the realm that I live in. And both of the cases I'm going to talk about today are not only real cases, but the information I'm sharing is actually available in public records. The first child was a 5-week-old baby who presented to the emergency department with a fever and what the physician described as irritability and lethargy. And they also used the term that the baby looked sick, which is code for those of us who work in the emergency department for a baby who could very well have a serious bacterial illness. And indeed, that physician felt that the risk of that was somewhere between 3 and 5%, which at least in my environment, we consider to be very high. At the time, the standard practice, and even today with a baby of this description, the standard practice would be to do a spinal tap, would be to do to collect blood with an IV and to collect urine, and then treat the baby with antibiotics in the hospital. The baby's mother, in this case, refused the spinal tap and the hospitalization and any treatment with antibiotics. And after extensive efforts at trying to persuade the mother to follow the medical recommendations, social work and CPS, Child Protective Services, were called, and the state was asked to intervene with that mother's decision. So you can think about that case as we sort of discuss the topics moving forward. But one of the things I wanted to say from the beginning was that for those of you who are versed in the principles of ethics, the principle of beneficence is really, in my mind, the primary principle that undergirds the healthcare professions. It's the obligation to do good to others, and certainly in a medical realm, the obligation of a medical professional to seek that good of the other, in most cases the patient, by avoiding the infliction of unnecessary harms, by preventing harms when that's possible, and by promoting the patient's good. So very much medicine is a form of applied beneficence. And if we think about this case, the emergency room physician, the nurses on duty that night, all had beneficence as their primary goal. They wanted what was best for that child. But it's also important to recognize that parenting is also a form of applied beneficence. And it's fair to say that Tage's mother also felt that the beneficent thing to do, what was in the best interest of her infant, was not to do what was being recommended medically, but to allow her to just take Tage home and care for him there. So what we really had in this case was not a conflict between principles, but a conflict about how exactly to interpret a principle. And I think this sort of understanding is an important one as we approach cases and situations that are centered on conflict, because in both cases, the parties are generally well-meaning and have their own reasons for wanting to do what they've decided to do. In general, in the United States and in many other countries, parents are given fairly wide latitude in making decisions for their children. And there are good moral reasons for that. There's good social reasons for that. And there's good, at least in the United States, good legal grounding for giving parents that authority. Now, parents don't technically give informed consent. Informed consent is really something only one can provide for themselves, but they give permission. They give you permission to do what they think or what you might think is best for their child. And parents are expected to make decisions that are based on the best interests of their child. And as I've pointed out, that the conclusion that a parent comes to may be different than the conclusion that professionals come to. Now, I want to make a sidebar here because we have seen, those of us who have been in the healthcare professions for a while have seen an increase in the number of situations, the number of clinical encounters where we find ourselves disagreeing with parents over what should happen with their children. And to some degree, this is the result of social phenomenon that have recently become fairly powerful. And I would include among those the notion of the sort of, for lack of a better term, the democratization of expertise, this sense that everybody's an expert. All you need to do is look on Google. And as a result, we have decreased trust in actual experts, people who are trained in fields. Social media has influenced that, and the presence of many websites that actually market in disinformation in an attempt to mislead people, which further undermines the expertise that some people have in general areas. And we have certainly seen this creep into the realm of medicine. There's also been a recent politicization of medical matters, and vaccination is probably the most prominent example of this, where for reasons that make no rational sense, whether one, for example, agrees with vaccination or not, is somehow determined by their political party. Again, a completely irrational approach to the problem, but nonetheless one that we're seeing. And both of these things have actually increased the degree of disagreement that we're seeing as healthcare professionals try to care for patients and in particular the children of parents who may have ideas that have been influenced by sources other than expert medical sources. Now, when we think about disagreements in general in the clinical realm, there are really two different kinds, and this is an important distinction because the kind matters. There are parents like Taja's mother who decline a medical recommendation. So she just wants the medical professionals to leave her child alone. She's declining what they are suggesting. There is a second category, which I will address briefly in a few minutes, where parents aren't simply declining a medical recommendation, but they're actually requesting something that the clinician may not feel is indicated. And we see this in many healthcare realms. It's not just asking physicians to prescribe something that's contraindicated, but it may be, it may present on the wards with a parent trying to direct a nurse to do her job in a way that's different from what she has learned to be the safe and appropriate way of doing those things. So we're going to start with declinations of medical recommendations. And this is why this is an important distinction, because by law, healthcare providers can't treat a competent adult, except in some emergency situations, without that person's permission. And likewise, that has been extended to children for whom a clinician does not have parental permission. And the only way around that, the only way to prevent that from being considered a battery under the law, an unconsented touching, is for the state to authorize that treatment. And that's why Taja's physician ended up calling Child Protective Services in the middle of the night, because that physician by themselves did not have the authority to simply do what Taja's mother was telling him not to do. So by and large, communication and persuasion are the clinician's primary tools. And diagnosing the reasons for a refusal can be helpful, and having conversations with families and in trying to persuade them or convince them that the approach you're recommending is in fact the best one for the child. Most of us consider requesting state intervention, which is the only other real recourse, to be a last resort. Now, what are the limits that of parental authority, at least in a legal scheme? And there are three of them, all of which are sort of related. The first is parental incompetence. If a parent can be shown actually to be incompetent, not have the capacity to make decisions for their child, they can be excluded as a decision maker and either replaced by somebody else or replaced by a state agency. Now, in my 30-some years of practice, I have never actually seen this happen. I have seen and cared for plenty of children whose parents appeared actually to be to not have the capacity to make the decisions that they're being asked to make, but have never intervened on that basis, perhaps because if we were unable to convince them that our recommendation was in fact best for their child, we would rely on one of the next two categories. And that second category is when a parent is being abusive or medically neglectful. Now, my argument would be that medical neglect is actually what's constituted in the third criterion. And so this to me is the most important state limit on parental authority, that the parent's decision violates the harm principle by placing their child at significant risk of a serious harm. Now, when that assessment is made, we have to remember that child interests are not always separable from family interests. And so this can be a difficult assessment to make. This is indeed a form of medical neglect. Medical neglect, by the way, is a term I really kind of disliked because these are rarely neglectful parents. And so the term itself is inflammatory, and it's really not reflective of what's happening. But notice that the harm principle sets a higher threshold for state intervention than best interest does, and that's what's important. So why the harm principle? John Stuart Mill, many years ago, wrote a small treatise called On Liberty, which was really John Stuart Mill's argument for the moral limits of the criminal law within liberal democracies. And the United States, Britain, and several other European countries fall under the category of being liberal democracies. And liberal is being used in a different sense here than many people are currently using liberal and conservative. What Mill said was the only purpose for which power can rightfully be exercised over any member of a civilized community against that person's will is to prevent harm to others. That person's own good, either physical or moral, is not sufficient warrant. Now, what Mill is really saying there is that from a moral perspective, the only valid exercise of state power is to interfere, and using state power to interfere with the behavior of somebody is if that behavior will place another person at significant risk of harm. Mill would say that if somebody wants to jump off a bridge, you can try to convince them otherwise, but the state should not be intervening in those cases. Because then only that person's likely to be harmed, and it's their decision. So the way this translates into the pediatric environment is that the parent is the one making a decision here. And if that decision places another person, in this case, the child, at significant risk of a harm that's serious and somewhat imminent, that constitutes a legitimate exercise of state authority. So again, it doesn't give the healthcare professional the right to just jump in and do stuff, but it does mean a threshold has been met where it is morally reasonable to involve state agencies and seek their help. The eminence criterion here is really related very much to seeking alternatives, and the argument there I would make about eminence is it doesn't need to be immediate, but if there is time, if harm will not result to the child immediately or in short term, then we should be trying to work with parents rather than involving state agencies. Now, Tage in the emergency department may have a serious bacterial illness. And those of you familiar with that situation know that Tage could if Tage in fact does have a serious bacterial illness, could become very sick very quickly. So this would clearly meet the eminence criterion. Now you can argue about whether the risk of harm is significant at 3 to 5%. The vast majority of clinicians I know would argue that it is. Very few people would argue that bacterial meningitis or sepsis is anything other than serious. And so most people, at least within the medical profession I know, would consider the harm criterion to be met in Tage's case. Now, you have to then go on and ask whether the interference of the state is necessary to prevent the harm and likely to prevent the harm. In other words, doing those tests, starting antibiotics, will likely prevent the kind of harms that can result from meningitis or sepsis. And it's not associated with a similar risk of similarly serious harm. So you have to look at the side effects of antibiotics. You also have to look at the harm done to the family by interfering with sort of the family autonomy to make decisions for themselves. And so all of those have to be weighed against the potential good that's being done. Perhaps the most important criterion is that no less restrictive alternative exists that would be equally effective at preventing the harm. So, and again, this is where persuasion is important and trying every means possible before invoking or seeking state intervention. And then I have two other tests that I've thrown in there. The test of generalizability is really my way of trying to address the possibility of implicit bias. What I personally do in these situations is, having decided that the child that this situation meets the criterion of the harm principle, I then ask whether I would still be calling a state agency if that family was just like me. They were white, middle class, kids went to the same schools my kids went to, they go to the same church I go to, dad is maybe a medical professional and mom is a professional. So very much like me, would I still be willing to call a state agency or get a court order? And if the answer is no, then you have a problem, because then you're basing your decision on criterion that should not be relevant in this situation, where the only real relevant criterion is whether the parents are placing their child at significant risk of serious harm. The test of publicity, it's one I included. I continue to have mixed feelings about it, but I threw it in there because in the cases I've been involved with where we were talking about getting a court order involving a state agency, there was always somebody from the hospital public relations office who was like, well, what if the public finds out about this ends up in the newspaper? And my argument was always, look, if we're really justified in doing this, we should be able to make an argument publicly that this was a reasonable decision. And that's what the test of publicity is. Now, does it matter if the parental refusal is culturally or religiously based? If for some reason Tage's mother was making her argument not from her maybe concerns about the medical interventions, but rather there was a religious reason that she didn't want this done. And my argument is no, that the only thing that's relevant here is that the child is being placed at significant risk of serious harm. The reasons are not important, except in understanding where the parents are coming from, perhaps finding some way of working with them, compromising, coming up with an alternative. Then it can become very important. But the bottom line is, simply because a parent's objection is religious should not change whether one interferes. And there is a legal basis for this as well, and that basis is essentially lies in the fact that when we talk about religious beliefs in the pediatric setting, we're talking about a parent's belief. And as Justice Holmes said in Prince versus Massachusetts, parents may be free to make martyrs of themselves, but they're not free to make martyrs of their children who have not yet attained an age where they can, in a very mature fashion, decide that these beliefs are also theirs. And so when we have religious objections to care, again, it's not that they're not important. We should use them to seek to understand where the parents are coming from. We should respect those beliefs. We should attempt to accommodate them if possible without placing the child at significant risk of serious harm. But in the end, they are not the deciding factor. So that's parental refusals of medical recommendations. Just a couple words when parents request things. So this, during the COVID pandemic, for example, we had some people requesting treatments that the medical literature showed were potentially harmful or showed no benefit. And what I want to say here is that this is a very different situation legally than when a parent is refusing something. Because as I mentioned before, for a clinician to do something against a parent's wishes is under the law a battery. However, when a parent requests something, the refusal of a clinician to do it is not a battery. And so it's a very different area from a legal perspective. And the short answer, or the short response here is that when parents request interventions, medical professionals have a great deal more discretion in terms of whether they will actually do that or offer that or write that prescription. So my approach to these is that they should be carefully considered, they should be treated respectfully, but they need not always be complied with. And I think there are some good reasons for refusing requests that a parent or even an adult patient may make. For example, when the likelihood of harm to the patient greatly exceeds the likelihood of benefit, or when the request falls outside the realm of accepted medical practice, or when the request falls outside the realm of your expertise. As an emergency room physician, I get asked all the time by parents, can't you just refill this prescription, or can't you just write a prescription for this? And they're frequently drugs that I have very little familiarity with. And in some cases may require follow-up to do EKGs and so on. And in those cases, I think I do say no. You need to go back to your other subspecialist or your primary care physician to get that done, because this is not an area that I have sufficient expertise to do this safely. In cases where an intervention really and truly won't work, I think we have grounds for refusing, and cooperating with the request in situations where it might harm somebody else, like pose a public health threat, may also be a good reason for refusing. And then we also have conscientious objections, where a parent may ask us to do something that maybe violates our own moral code. And in those cases, conscientious objection may be a legitimate motive, a reason for refusing that request. So again, in the situation where parents request things, we should consider accommodating them, particularly if it's not going to hurt the child, if it doesn't hurt other people, and if there is a possible, maybe not proven, potential for benefit. When those conditions are met, I think it can be considered. And also when it falls within the scope of the provider's practice and the standard of care. So let's turn our attention now to situations where there are older kids involved who may have their own thoughts or opinions about a situation. So William Blake said, neither youth nor childhood is folly or incapacity. Some children are fools, and so are some old men. And I just want to recognize that reality, because where you draw the line here is very tricky, and different people will draw the line in different places in terms of when somebody should actually have the ability to make decisions for themselves in a healthcare realm. And in reality, it also depends on the kind of decision being made and the kinds of risks that are inherent in that decision. So let me tell you about the second patient. Daniel Hauser was a 13-year-old from Sleepy Eye, Minnesota, who was diagnosed with Hodgkin's lymphoma, and the data suggested he had a 90% chance of cure with standard chemotherapy treatment. And he underwent one round of chemo, and as chemo tends to do, he lost his hair and he got sick and didn't feel very good. And that led him to believe that this was poisonous, which, quite frankly is accurate. That is what chemotherapy is. And the idea is it poisons cancerous cells more than your own body's cells. But Daniel also claimed to be a medicine man and a church elder in an American Indian religious organization called Nemenha. And my understanding is that to be a medicine man, he simply needed to mail in some money and he got a certificate, and that there was not some elaborate training or ceremony or something. And to my knowledge, Daniel was not actually Native American, but nonetheless, he claimed treatment would violate that religious belief, and he claimed chemotherapy was self-destructive and poisonous, and as a result did not want any more chemotherapy, but rather wanted to pursue an alternative regime of complementary medicine that included dietary changes and ionized water and all other things for which there's no data whatsoever that it has any positive impact on cancer treatment. And Daniel went as far as to say that he would physically resist if anybody attempted to give him chemotherapy. So how do we approach situations like that? Now, we can look at the current legal framework and look at the legal reasons adolescents are sometimes allowed to consent. And I think it's worth doing that because it puts the kind of decision that Daniel Hauser was trying to make in context. There is conditional consent, which is actually not provided by adolescents or parents. This is the kind of consent that I may have in my emergency room practice, where a parent is not accompanying a child who's having an emergency medical condition, and I need to stabilize that. And I, in all 50 states, am authorized to do that. Not me personally, but an ER physician. All 50 states have a law that authorizes them to act in an emergency when there is nobody there to provide consent. There are emancipation minor laws in most states, and Michigan has one of those. And to be emancipated, minors generally need to meet certain criterion. Either a court order has been issued declaring them emancipated, or they have married, or they're active duty in the military. And I believe Michigan's includes marriage and active duty military service. And then finally, there are what I call condition-specific exceptions, which allow adolescents, and there's more variability here from state to state, to consent to certain kinds of medical treatment. And they are almost always things like sexually transmitted disease diagnosis and treatment, pregnancy-related care, and psychiatric and mental health care, which includes drug and alcohol treatment. Now, those state laws generally give adolescents the right to consent without parental consent, and there are reasons for that. They are generally public health reasons, and it's because these are all things that if some adolescents were required to involve their parents, they would simply not seek care, and it would create not only a health hazard to them, but a health hazard to others potentially. And then finally, there are mature minor laws. And what Daniel Hauser didn't meet an emancipation law. He did not have one of these condition-specific exceptions. And he had a parent present, so conditional consent in an emergency didn't apply. So what he was really appealing to was something that only some states have, and that is the notion of a mature minor. And in those states that have mature minor laws, generally somebody who's 15 or above, who has demonstrated to show an understanding of the nature, purpose, and consequences of proposed treatment, will be allowed to make those decisions. Now, states vary on whether a physician can make that decision or whether it requires a judge. And they also vary on what conditions need to be met. And there's a great deal of variability in terms of whether a state even has those. Most states do not have mature minor doctrines. So what does ethics have to say about this? The traditional ethics approach was initially outlined almost 30 years ago by the American Academy of Pediatrics, where they said that there are clinical situations in which a persistent refusal of assent may be ethically binding. A patient's reluctance or refusal to assent should also carry considerable weight when the proposed intervention is essential to is not essential to his or her welfare and can be deferred without substantial risk. And the point I want to make here is this statement is often used to make an argument that that the AAP said adolescents should be able to make the kind of decision that, say, Daniel Hauser was trying to make. But in fact, it does not say that. It says that when the proposed intervention, it only includes interventions that are not essential to the welfare of the adolescent and can be deferred without substantial risk. And that was not true in Daniel Hauser's case, and it's not true in many of the adolescent cases that have come to public attention. The factual basis for this argument was grounded in studies done 40 years ago by Lois Wiedhorn and her colleagues. And what Lois Wiedhorn basically demonstrated was that the typical adolescent really had minimal capacity to make complex medical decisions up until the age of 12. But at about 12, something happened where they actually had more of the cognitive machinery that would allow them to make these decisions. And she demonstrated that nicely, somewhere between 12 and 14. So there's this developmental evidence of progressive decision-making abilities. And many people were making the argument in the 90s and 2000s that adolescents should be given more latitude in decision-making because of these studies. However, there were others, including myself, who noted that the data also showed, though, that even if adolescents had the ability to do this, they often didn't perform at that level, that there seemed to be some kind of a disconnect there. And that's where I think it's really important to take a quick look at the adolescent brain and adolescent brain development and ask ourselves whether the brain of a Daniel Hauser at 13 or a 17-year-old is truly at a point where they should be allowed to at least make life-limiting decisions, okay? So here's the deal in very broad brush strokes. Our brains are really two-system brains. Our brains operate sort of with two parallel systems, one of which we're aware of. That's what some people call the rational brain. It's composed of the prefrontal cortex primarily. And then there's something called the social-emotional brain, which is comprised of many of the limbic structures. And those are, that part of the brain we are not consciously aware of, but it greatly impacts our decision-making and our emotions. Now, maturation occurs in a way that's described as back to front. And what that means is that those limbic structures, the social-emotional brain, mature considerably earlier than the prefrontal cortex does. The prefrontal cortex, as a matter of fact, doesn't really mature until the mid-20s, and it matures about 2 years earlier in females than it does in males. So the other way to look at this is that social-emotional brain is really sensation-seeking. It's being driven by the way you feel and the emotions you're having. The rational part of the brain is the brakes. It's the part of the brain that's saying, whoa, wait a minute, we should think this through. And those two, even in adults, continue to exist in tandem and work together when all things are going well. The reality is that even adults make many of their decisions based primarily on the social-emotional brain. The kinds of things we buy, the way marketing is done, are largely based on our emotions and the way we feel. And good marketing appeals to our emotions, not our rational thought processes. That's how they get you to buy that pretty red convertible in the car dealer. And that's how, and Apple is a master at this with the way they've designed their Apple Store, because they feature their products, which are beautiful. They make you pick them up and play with them. And the idea is you're going to fall in love with that product before you've really had a chance to think through whether you really need it or not. So this is relevant to all of us, but the difference with adolescents is there's a much more significant imbalance where they've got a very active socio-emotional brain and a not quite as powerful prefrontal cortex. And in the words of Lauren Steinberg, who's one of the primary scholars in this area, the adolescent brain has a well-developed accelerator, but only a partly developed brake. The implications of this, something that I sort of jokingly refer to as prefrontal cortex deficit disorder. It explains why many adolescents at times, and again, this is not all the time, but at times can be impulsive, inflexible, aggressive, reckless, emotionally volatile. We clearly know that adolescence is a time where they take risks, they're reactive to stress, they're vulnerable to peer pressure, they underestimate long-term consequences, and all of those are the result of an immature, not fully developed prefrontal cortex. Can they consider long-term consequences? Absolutely. Can they resist peer pressure? Yes, but it's extraordinarily difficult to do so, particularly under certain conditions and in the heat of the moment. One of the things we've learned about adolescent driving behavior, for example, is that if you really want to reduce car accidents among adolescents, you restrict who can be in the car with them. In other words, most adolescents are safe drivers if it's just them or if they're driving with their parents. But if you put 3 friends in the car with them, even the safest adolescent driver or the one with the skills to be safe is more prone to drive recklessly. And that is part of this imbalance that exists. So it's important to recognize that while adolescents are very good at decision-making tasks, including medical decision-making tasks, there are situations where they are not so good at that. When there is an emotionally charged situation or where they're under pressure, especially peer pressure, they will not be as good at making those decisions. The interesting thing about almost all of the publicly popular adolescent refusal cases is that they are almost always situations where there's a parent supporting the adolescent's decision. And what people don't fully recognize is parents are peers. And what has become clear to me in some of these cases is that the adolescent is in many cases echoing what their parents are telling them. And they have just been sort of put front and center, so it looks like their decision. But the reality is that it's being driven by the peer pressure applied by their parent. Adolescents are very sensitive to environmental cues and affective elements and rewards and punishments and the presence of peers, all of which can be a factor in decisions related to medical conditions. And they're much more likely to weigh current rewards over future consequences and act compulsively without full consideration of consequences. So that's all to say that I think adolescents should be involved in discussions and decisions about their care. We should recognize they have a developing capacity to make decisions, but recognize also that even at 17, their decision-making may differ from truly mature decision-making, and recognize that the kinds of situations in which decision-making may be flawed are particularly risky. So adolescents need limits and direction. But beyond that, physical restraint always requires justification. So to me, the most concerning feature of Daniel Hauser's case is that he threatens to become physically, to resist physically if we try to intervene. Now, that doesn't mean he will, but one of the decisions that needs to be made is, will we really put him in 4-point restraints to accomplish this if we need to? And that requires a higher level of justification. The bottom line for me with adolescent decision-making is that if a decision is one that we would not allow a parent to make on the adolescent's behalf, because it places the child at significant risk of serious harm as compared to the rejected alternatives, we should be very reluctant to allow an adolescent to make it. So in Daniel Hauser's case, if Daniel were 7 and his mother was trying to refuse treatment for a cancer that had a 90% chance of survival, almost everybody I know would feel that meets the conditions of the harm principle, and we would try to get a court order. That shouldn't change just because he's 13. However, for decisions of less consequence, I do think there is a role for adolescents to be making decisions, particularly if it falls into a category that we would allow a parent to make. And so, for example, I am an advocate for allowing adolescents to make decisions about vaccinations and other treatments like that. So, the final thing I'll say is that procedural justice is important. And when we do encounter these conflicts clinically, it's important that there be a process for resolution of disagreement that's fair and transparent and conclusive. Thank you very much.
We're going to go to our second speaker now, Dr. Dominic Sisti. So Dominic, the screen is yours.
Thanks, Dr. Fonner. Thanks, everyone. Thanks, Dr. Koch. Thanks to all the folks who organized this wonderful colloquy. Let me see if I can share my slides. So thanks, everyone, again. My name is Dom Sisti. I'm from the University of Pennsylvania. I just have a few acknowledgements before I get started. First, again, just thanks to the planning committee. Really a privilege to be with you for this tradition, and I'm really delighted. Thank you all. I wish I could be there in person. The Thomas Scattergood Behavioral Health Foundation, which funds quite a bit of my research, Leonard Davis Institute at Penn, and my department at Penn, both of which are supportive of my research and lots of great collaborators. I don't have any conflicts of interest to disclose. So as Dr. Diekema likes to begin his presentations with a case, I like to begin my presentations with some Kant. And this slide presents the first kind of opening sentences of one of my favorite Kant essays called An Answer to the Question, What is Enlightenment? And, this full essay is about society's emergence from a kind of darker place where society, en masse, there was a realization that, hey, maybe we can actually rule ourselves, politically. And so this is an account of the emergence out of sort of monarchy and authoritarianism and religious authoritarianism. But if you single out it, individuals and think about it from that perspective, it still makes some sense. And what Kant says is that enlightenment is one's emergence from self-incurred immaturity. Immaturity is the inability to use one's own understanding without the guidance of another. This immaturity is self-incurred if its cause is not lack of understanding, but lack of resolution and courage to use it without the guidance of another. And therefore, the motto of the Enlightenment is sapere aude, have the courage to use your own understanding. Another way to translate that is just dare to know. And so this sort of doublet or paragraph of this essay kind of sets up what I want to talk about tonight. On the one hand, we sometimes need to recognize a child's immaturity and do its best for them. On the other, we want to sometimes, instill in them a sense of courage to get them to a place where they will begin to act in a way that's more mature. So I see some of the issues that we're discussing tonight as variations on the principle of respect for persons. Dr. Diekema really focused in on how beneficence is the sort of keystone principle. And I agree, actually. I think beneficence is, as Edmund Pellegrino used to say, really the keystone principle that encompasses all the others. I mean, a beneficent physician is going to respect the autonomy and the personhood of his or her patients. So while I agree that beneficence is overarching, I want to focus in on the principle of respect for persons. And I want to look at respect for persons in a couple of ways. My central claim is really that clinicians, parents, and policymakers have an ethical obligation to respect minors' personhood in at least three different ways. There's probably others, but these are just the three I want to talk about tonight. The first is to protect vulnerable persons. individuals who are non-autonomous but are still part of our moral community, to respect nascent autonomy in individuals who maybe are adolescents who are beginning to form their value system and understand what their self-determination entails, and to try to respect that and cultivate it. And then third is to cultivate the intellectual and moral virtues allied with individual autonomy and enlightenment. And these might include virtues including courage, perseverance, patience, etc. So we'll get to that soon. And let me just, by review here, mention what informed consent looks like, because what we're talking about with kids isn't technically consent, right? And as Dr. Deacon described, even when a parent does it, it's not really consent, it's permission. But just by way of background, remember that consent, informed consent, has two preconditions. The first is that the individual must be free and voluntary. And the second is that the individual must have capacity for the specific decision. Neither of these conditions is met by a minor, for various reasons. In some cases, it's just by definition that a minor just doesn't have capacity. But really, when you think about what the life of a minor, they're very dependent on parents, caregivers, peers, et cetera. They're not really free. So we're not talking about consent. And certainly, when we think about capacity in kids and minors, as Dr. Deacon alluded to, we can, in fact, see that they meet most of the criterion that are laid out in this particular table, which is sort of a crystallization of the Applebaum-Griso criteria for capacity, kind of the gold standard of capacity evaluations, that lay out 4 different criteria: communicating a choice, understanding relevant information, appreciating the situation, and reasoning about the actual treatment options. These 4 different criteria serve as a nice nice thumbnails for ascertaining capacity in adults. In kids, it's tough because they can actually meet the criteria here, but still, I think, be incapacitated, technically speaking. And that's because a lot of what I think we focus on in capacity evaluations turns on, sort of mechanistic or procedural capabilities to be able to kind of go through a process, read a form, answer questions somewhat logically, think through things. And, lots of minors may and do possess that kind of procedural capacity. They also possess a certain logical level or logic analytic capacity that allows them to manipulate information in ways that are pretty sophisticated. And so, on both scores, I think, from procedural capacity and analytic capacity, many will pass. The problem is there's a lot going on that interferes with these 2 capabilities, as Dr. Deacon kind of got to at the end of his talk. And that's, just the fact that a lot of kids get swayed by peer pressure, have highly impulsive behaviors because their prefrontal cortex is not fully developed. The circuitry that runs their emotional regulation system is still immature, and their limbic system is still developing. So they're highly emotional. So notwithstanding the fact that we can kind of get them to a place where they'll kind of agree with us, understand what we're talking about, be able to agree to things, it's likely the case that they're not fully capacitated on certain, in certain decisions that are really like high stress, maybe high risk interventions are being discussed, and the possibility of severe illness or severe death could be part of that calculation, and they just don't have the experience or apparatus to really fully grasp those things. And so we have to sometimes decide, for others, decide for our family members, decide for our kids, and there are various standards that are used in bioethics, as you all know, to kind of circumscribe these various types of ways of deciding for others, whether it's, substituted judgment, which is when the individual is, you as a proxy is trying to kind of enact the values of the individual. And in cases of minors, it's not really it's kind of a moot standard, because what we're saying is they weren't really ever autonomous. So we shift over to the best interest standards, as Dr. Diekema described in his talk. There's all sorts, there's various policy architectures and frameworks around not only the US and various states, but around the world that try to give some, legal framework around understanding children's decision-making rights in healthcare. And, in the US, there's this mature minor doctrine, which allows individuals who are adolescents, let's say, who are 14 years and above, to consent if they can generally understand the nature and consequences of their treatment. It's not a high risk treatment, it's minimal risk. And, the procedures are for, life-sustaining treatment, et cetera. That might require additional intervention by a parent, a physician, a judge, to support that decision-making process. In the UK, they recognize that adolescents 16 and up can basically make their own decisions. This is the Gillick test is what it's called. And in fact, many of our laws are kind of derived from the UK's Gillick kind of common law structure, and the sort of rule of sevens, where it's like 0 to 7 years of age, they're totally incapacitated. 7 to 14, we're starting to see some capacity and begin the process of accepting assent and bringing in their values and their opinions. And then sort of 14 to 18 is like pretty much autonomous, et cetera. So the Gillick competency standards undergird a lot of what we do in the US, in fact. And then, in other countries in the EU, Switzerland, there's no real distinction based on age, but on capacity. Germany, 14 years. The Netherlands, can be down to 12 years. And in fact, in the Benelux countries, children and adolescents are now empowered to make very significant decisions around, in fact, euthanasia. And while they don't have full autonomous right to make a request for euthanasia, they can be involved and can trigger a request with the support of parents and physicians. I noticed a question in the chat while Dr. Diekema was talking, and that was a question related to the whether Michigan has an emancipated minor law, and in fact, Michigan does. So I just threw the slide together while Dr. Diekema was speaking, and I'll just put this up here if you want to go look at. This is a Kaiser issue brief, and there's one for every state, and these are very handy. So here's the one for Michigan. In fact, there is an emancipated minor law, and there's links there for details. What I want to do now is just kind of review quickly some of the major frameworks in pediatric decision-making, and then crystallize what I think are ethical considerations that cross-cut all of these approaches, and then just kind of give my own take on some of these basic issues. So as we just discussed, as Dr. Diekema just discussed in eloquent detail, the best interest standard is really a baseline framework for understanding how best to take care of patients, rooted in this idea of like reasonable treatment, reasonable risk, reasonable benefit. And the threshold here for intervention is parental neglect or abuse potentially. Similarly, with the harm principle derived from I think best interest in the beneficence principle. Similar idea in this the framework by Lynn Gillum, known as the zone of parental discretion. It's noted that this allows for disagreement with parents when parents are kind of requesting something that might not be super safe, but isn't especially harmful. Maybe you can go with that. That's within that zone. Or if they're refusing something that might be sort of marginally beneficial, but kind of risky, and you could kind of, as yourself maybe see their point, that might be part of, you might say that that's in the zone of parental discretion. And, Gillen gives a whole way of examining these choices and applying this framework. Constrained parental autonomy is another very, this is one that I teach a lot. This is Lainey Friedman Ross's approach that basically shows how there's going to be decisions and trade-offs within a family around a child's best interest, and even other family members and priorities within the family can take kind of can be taken into account in determining what's best for the particular patient who's sick. But it's within a certain range. And so that's what the constrained authority looks like. And again, Lainey Ross, her paper, I have a copy of it coming up, and you can take a screen grab of it. It's really worth reading. And then the IPO framework is the idea of the impermissible, permissible, obligatory set of distinctions related to various interventions when you're looking at risk benefit. So just as as a slide that gives kind of, this is from a paper by Jonathan Marin about the infamous, I think, case of Billy Best. They really did a nice job of summarizing the major frameworks, and I just wanted to review those before I just describe what I was going to, sort of talk about as my own inclinations here around taking care of kids who either refuse appropriate treatment or who desire appropriate treatment, but who have parents that are not really cooperative. And so respect for persons is like, again, it's this principle in the Belmont report. It's actually related to research ethics more so than clinical ethics, but the principle of respect for autonomy is derived from respect for persons. And respect for autonomy really applies to the informed consent process in adults incapacitated minors or emancipated minors and refusals of both groups. So we're talking in terms of respect for autonomy, we're talking about capacitated individuals. We're talking about respect for persons in the other way. We're talking about protecting vulnerable, non-autonomous persons who have nascent values. They don't really have full values yet. They haven't really matured to a place where their values are fully coherent or coherent. And so we might see two types of cases. The first is when an adolescent maybe refuses appropriate treatment. And in these cases, we're just going to assume, since Dr. Diekema really spent a lot of time talking about parental disagreement with physicians, let's just assume that parents and physicians kind of agree and think about what happens with an adolescent who's refusing appropriate treatment. In those cases, we may invoke something I'll call non-voluntary treatment in an effort to minimize harm, advance health. You're going to override outward wishes. And we can talk about what that looks like in practice. Again, restraint is extremely traumatic and requires a very high level of ethical justification. Let's just talk about three cases in a minute: ADHD, anorexia, and anxiety disorder. And then, another kind of family of cases is when a patient, a kid, an adolescent, a minor, desires something that's actually really appropriate and really good, but and potentially life-saving, in fact, but in fact causes, maybe puts them at risk. With their parents. Their parents actually don't want them to get the intervention, and so we're stuck in a situation where we have parents who are recalcitrant, neglectful, abusive, ignorant, or whatever, and so we have to figure out ways to give these kids the treatment, empower the children, empower the adolescents, empower the young adult almost to access the healthcare they need. So we'll talk about each of these broad sets of cases in a second now. So let's talk about anorexia nervosa. First of all, we see this in children's hospitals all too frequently, where there's a young, oftentimes female patient who has an eating disorder, anorexia, bulimia, and it may be the first time, it may be a time, maybe it's, whether it's the first time, second time, third time, we may encounter a patient who is refusing continued treatment because, these treatments can be quite invasive and difficult and require supervision. There's not a whole lot of privacy sometimes with really sick patients who need to have a one-on-one perhaps. It's a very stressful kind of treatment course often. And so you might have patients who don't want to pursue that course. Maybe they've experienced it once and it was highly traumatic and they don't want to do it again. They don't want to have two feedings. They don't want to be at the hospital. They want to be at home, whatever. it's highly controversial to restrain a patient in this state. So, it'll be highly traumatic, but it may also be life-saving. And, anorexia carries the second highest mortality rate of all the DSM-5 diagnoses after opioid use disorder. So one can sort of justify something that is really high risk, like 4-point restraints or some kind of sedation, perhaps, while you place lines and get calories in the individual, compared to death, right? And even like in cases where an individual, where a patient has this very significant or serious illness, they may have certain rational processes that are intact and still be able to kind of articulate the desire to no longer be treated for the anorexia. So even a very physically compromised individual can still make claims that seem coherent. On the other hand, one might want to ask, like, what are those claims based on, like, fundamentally? And I think, depending on how we conceptualize anorexia, it can be considered a disease of impulsivity and compulsivity, where the individual has a compulsion, almost like an addiction, and has lost essentially control of their executive function, of their function, really. And so we might say that they're no longer even nascently autonomous or able to assent. They have, really their executive function and their frontal cortex is just offline, we might say. The other thing is, like, the actual physical effects of the disease can certainly affect, psychological, cognitive, emotional functioning. So all these things, I think, conspire to present us with cases that are often justifiable in terms of forced treatment, what we'll call compulsory or coerced, compassionately coerced treatment, we'll call it. These are often patients who have deep trauma sometimes. They may have substance use disorders. There might be comorbidities that interfere with, I'm just thinking back to a few of the cases that I've heard about at CHOP, at the Children's Hospital of Philadelphia, and at Penn. Actually, a lot of those patients at CHOP were, pediatric patients, but they continued to present at the CHOP ER or at CHOP in their 20s. Because they've had a long course of, illness, and they just have been followed for so long. So they just continue to go to CHOP. That might be the same at Seattle Children's. I don't know. But I know, folks, with this disorder have very unstable values, fluctuate decision-making, can be impacted. So this is one case where I think forced treatment is actually justifiable, especially if, again, we're assuming parents are supportive. We want to do the best thing for the patient. And I don't really call it involuntary treatment in these cases, because involuntary presupposes there was a voluntary, which itself presupposes that the individual had autonomy at one point. We're talking about patients who are still minors, and really it's not going from voluntary to involuntary, but rather going from sort of something to something else. It's not, you're not going from voluntary in the sense that the person knew exactly what they wanted, and now you're overriding what they wanted. You're kind of working with somebody who's already lacking capacity and doesn't really have coherent value. So I use the term non-voluntary, kind of drawing on that tripartite distinction in euthanasia, actually. Euthanasia discussions around voluntary, involuntary, and non-voluntary. And non-voluntary in euthanasia is when you don't really know what the values are of the person, but you think it's in their best interest to provide them with end-of-life care euthanasia. In this case, it's the non-voluntariness is that you don't really trust what they're saying, they're compromised, you're not really sure they have coherent values to begin with. So you're going to treat them and hope that that they're glad that you did so. And we'll talk about that in a second. So this is just what I just said. Involuntary suggests a person possessed capacity and is now refusing an intervention. Involuntary means the person will be unhappy to receive the treatment longer term, and involuntary suggests there's forced treatment on a person in opposition to like their deepest values. I'm just gonna see if I can just come back to those two slides in a second, but I would say that non-voluntary treatment in kids is ethically justifiable when there's evidence of significant suffering. There's risk of further disability or decompensation. The safety to themselves or to others is at risk. The beneficial treatment is in fact available, of course. And there's evidence of rudimentary values within the patient that favor recovery. So maybe they were on a sports team, maybe they had a friend group that they enjoyed hanging out with. They were a part of some club, they were doing things in the community. Those types of things, kind of are indicators of engagement in the world and life projects. And I think, we can use those as evidence for wanting recovery to kind of justify what would be non-voluntary or treatment over objection in these patients. And I draw on here Alan Stone's thank you theory. Alan Stone was actually a forensic psychiatrist, recently died, but wrote lots of great stuff about the both about forensic psychiatry as a practice, but also the ethics of forensic psychiatry. And one of the key questions is, would the patient appreciate treatment over objection after the fact? And it turns out there is some evidence that younger patients, at least in mental health care with schizophrenia and affect disorders, often would express gratitude after treatment. Patients who maybe had a significant psychotic syndrome or a crisis, and who were refusing treatment but were involuntarily committed, and they were given the treatment they needed, the medication, the therapy to restore their autonomy, and eventually leave the hospital in recovery, express gratitude, right? So if we can, I think, apply that same thinking to cases in adolescence, we'd be in good shape ethically. As I mentioned, this is just a schematic that I put together, just that summarizes this paper by Paul Applebaum and George Muckler. But the idea here is that compulsory treatment is always the most ethically fraught and requires the highest level of ethical justification. So these are various ways of leveraging or influencing a patient to get them to do what you want them to do or what's in their best interest. Each of these is a common site in clinical wards and settings. But when we get to a point at which threats and compulsory treatment are an option, we need to really have our ethical justification ducks in a row. So that's non-voluntary treatment. Let me just talk a bit about assent and sort of this middle set of cases between sort of pushing or sort of compulsory treatment to sort of empowerment, right? This is the idea that you're working with adolescents and children to get them to sort of agree or understand what your treatment is and what the risks and the benefits are for them, and kind of give a nod to the treatment and sort of provide their stamp of approval, as it were. And this is a paper I wrote with a colleague, Anson Koshi, who's a pediatrician, was a postdoc when we wrote this many years ago. And the example we use is ADHD to make a case that there's certain conditions, certain interactions and treatments that really do require assent. And we argue that ADHD is one of those conditions in kids. Now, I'm going to say right now, I disagree with myself, actually, but I'm going to present this paper as if I agree with it. But I did change my mind, and I'll tell you why in a few minutes. First off, assent is an ethical imperative because we can begin the process of respecting children's emergent autonomy by bringing them into the conversation around the treatment course for their ADHD. It involves, encouragement, involves, the idea that you'll have a, you'll be better at maybe at schoolwork. You'll talk to them about their social situations. You'll begin the process of letting them understand that, with medication and treatment, they may have a better life, essentially. And that seems totally reasonable, seems important, seems like a conversation that should be had no matter. The issue we found was that in terms of ADHD treatment, there's not, a lot of the clinicians that or a lot of the concerns from clinicians around assent in some of these particular cases, in particular in ADHD, is that they don't really have, the confidence that individual patients have really any autonomy to or capacity to even assent. And they don't really know or understand what it may mean. And so, and they might not have time to really go through this process of assent in ADHD. So that's an interesting problem. And in terms of parental concerns, there were issues around stigma around stimulants, and authenticity will be undermined. And so parents were also kind of worried about treating their kids, with psychopharm, with stimulants, for example, because, they thought, oh, my kid will change, the kid will be inauthentic or whatever. And kids kind of, were told this essentially by their parents. As Dr. Deacon was saying, it wasn't so much that the kids thought that, but I think they picked up on these attitudes that are kind of prevalent around ADHD and medicating for ADHD. Turns out those attitudes are empirically false, at least according to Dr. Alina Singh's work, which shows that in treating kids with ADHD, they feel great. In fact, the interviews that she's cataloged over the years show that kids are saying, no, I'm actually feeling more like myself, et cetera. And so they're pretty, once they're treated, they have a pretty high level of insight into the treatment itself and recognize that it helped them, and they're thankful. The question is before the treatment. And so when I wrote this, I didn't have kids. So I thought oh yeah, we got to get them in the loop on this. And it's really just part of developing autonomy in these kids and helping kids cultivate their self-determination. As a parent now with a child who has ADHD, I recognize that it's not that easy. And so it's an issue where I think there's some non-voluntary treatment that has to happen up front often. And we develop through, after the treatment, that treatment unlocks the circuitry to allow the patient to begin to develop, more autonomous ways of, functioning, thinking, behaving. And so I think this is one of those cases where I wrote a paper, I had some life experiences, and I changed my mind. There's a few others like that, to be honest. In informed consent, so this is the American Academy of Pediatrics white paper and set of standards, and Dr. Deacon probably wrote these around assent elements, but the idea is that you're helping a patient achieve developmentally appropriate awareness of the nature of their condition. You're telling the patient what they can expect with tests and treatments, making a clinical assessment of the patient's understanding of the situation and the factors influencing how he or she is responding. And then you're soliciting an expression of the patient's willingness. On this point, we note that no one should solicit a patient's views without intending to weigh them seriously. So it's not just about asking them as a rubber stamp. I kind of said that, but it's not. It's like, this has to be taken seriously in situations in which the patient, especially has to receive medical care despite their objection. The patient should be told that they're going to get it anyway, and that's got to be upfront. You can't deceive them. So, all these things make assent pretty complicated at times. It's certainly not consent, right? It's not legally effective by itself. It supplements proxy permission, parents' permission again, may not require the same level of comprehension or reasoning. But again, this is sort of training wheel consent. And whether or not assent is required depends upon the seriousness and consequences of the maturity of the child. In ADHD, I really think assent is ideal. but it isn't an obligation. That was just too strong of an argument, I think, in that case. Going, on in the white paper, the American Academy of Pediatrics also says dissent by the pediatric patient should carry considerable weight when the proposed intervention is not essential or can be deferred. So, dissent on psychiatric medication or ADHD treatments it might make sense to defer until a patient is able to really understand what's happening, if there isn't substantial risk, if they can get through the next few months or whatever it might be without medication. If the medication is helpful, maybe they'll understand better, the weight of the intervention itself, and continue on and do it voluntarily without being forced. But maybe they just need some time to understand and deferring treatment. And again, if the likely benefits of the treatment and conditions with a good prognosis outweigh the burdens, then parents should choose a treatment plan over objections or dissent of the minor, and they shouldn't be allowed to refuse that. When parents agree with a refusal that's ill-advised, Dr. Dikema has talked about that. There's all sorts of interventions and unfortunately judicial action that can happen. We want to, again, weigh assent as a serious thing, and we want to weigh dissent as a serious thing. I'm just going to skip this slide because I'm running a little bit low on time here. But this is, okay, that's Laney Ross's model. So let me just real quick shift now to my third set of cases, which is where we want to try to help kids actually access healthcare that they need or that they want. That's good for for them in particular as individuals, but also has potentially a public health consequences. And so here's a paper by a group of authors, Ross Silverman, Doug Opel, and Saad Omer, where they lay out the argument for vaccination over parental objection, or allowing or encouraging individuals, pediatric patients to access vaccines. And they, here you can see a number of different laws. This is from 2019, I think. And this paper is a little bit out of date, but it does show that many states do have laws that protect an adolescent's right to consent to healthcare. There's STI-related consent. There's consent to reproductive healthcare, other kinds of things that are waived, and parental permission is waived in such cases. So there's a number of different states here that you can see have laws that are amenable to the idea that adolescents can consent to their own kinds of treatments. And I've written a bit about this in the COVID vaccine space with colleagues Larissa Morgan and Jason Schwartz on the need to create policy structures to allow and encourage kids to get the COVID vaccine without their parents' permission. And again, just a sidebar, again, as Dr. Dikema mentioned, there's a lot of social shifts in the air, political shifts where parents, patients, individuals think they know a lot about things that they actually don't really know a lot about. The COVID vaccines happened to be one of those unfortunate examples where individuals thought that the vaccines were unsafe or that they carried some kind of microchip or were magnetic or all sorts of horrible misinformation that was perpetuated by various people to scare folks. And so now there's a population of folks who have kids that believe the wrong things about vaccines. And so it's not really fair to the kids to subject them to that kind of, sort of medical neglect and ignorance and risk of COVID, recognizing that it isn't a great risk, right, to kids, but it's still a risk. Moreover, it's a risk to everyone else because kids can be spreaders. And so, given the social shifts in in skepticism around expertise, around vaccines, et cetera. It's really, I think, important that we enable kids to get the vaccine if they want it themselves and understand it, because a lot of kids actually have a more sophisticated understanding of the biology of these vaccines than their parents, who might be of this, the group that's resistant or vaccine skeptical. So I think that's really important to sort of to emphasize, is that we're not just talking about treating kids against their wishes or trying to negotiate various interventions for kids that they're like resistant to or their parents might be resistant to. But I think there's an ethical obligation to be proactive in getting kids what they want and giving kids the means to be responsible citizens, right? So there's a kind of a virtue training here, and virtue in the philosophical sense of creating good citizens, creating thoughtful neighbors and community members. And I think one way to do that is to allow them, to give them the policy mechanisms they need to do the right thing. The objectively the right thing, which is getting the COVID vaccine. Right now, there are a lot of states that most states actually also that have that require parental permission for the COVID vaccine, which really makes no sense. I mean, it's a very safe and highly effective treatment. So it seems sort of like it should just be handed out to anyone who wants it, given, there's some medical contraindications, I guess. But on the whole, I mean, the idea that you can get Tylenol at a nurse's office, that your kids can get that at school, it seems like they should also be able to get the vaccine at school without much to do. But you can see here that there's just most states haven't really taken this idea seriously to allow for kids to get vaccinated without their parents' knowledge or consent. But that's not without a lot of advocacy and work by some really, really incredibly smart teenagers themselves who have taken this cause up themselves to get folks, their peers, educated on how best to get healthcare when their parents maybe aren't exactly the most cooperative with them. So just checking up my time here. Okay, so good, we have some time left. The group I have highlighted here is called VaxTeen. It was founded by Kelly Danielpour, who was a high school student out in California. She's, I think now at Stanford, but there's chapters all around the country. And this is a group of young people, young adults, teenagers and adolescents who are working really hard to educate their peers about vaccination, and also lobby state governments to allow teens to get vaccinated without their parents' consent in some cases. So VaxTeen is a great example. I think this is a group that physicians and hospital systems, groups out there, advocacy really need to kind of know about and support. It's one of many teen run groups related to their healthcare, and we should support them. Similar is access to abortion, and in the U.S., as we know, things have taken an interesting and difficult turn where abortion is now illegal in like 13 states. It's banned in 13 states, and we now have a situation where it's just become crisis. And so now, there are states that allow adolescents to access reproductive healthcare services without parental consent. But those states are fewer and further between. This is a crisis that we're going to need to really address. I think the key point here again is that we want to create policy frameworks for young adults to be able to get the healthcare they need without without parental interference, where the parental interference might be harmful. We don't want to set up kids for further abuse, neglect, or difficulties with their families if they were to access healthcare without consent. But we do want to create these frameworks to allow them that option, to give them that option in a safe way. So again, they can begin the process of taking ownership of their healthcare and eventually transition from adolescent pediatric care to adult care. So let's see, what do we have next here? Returning back to our earliest slide, which was Kant's essay, What is Enlightenment? Remember that we're talking again about kids who are immature. That's not a self-incurred immaturity. Remember, Kant was talking about adults who refuse to be mature. They have the skills, they have the apparatus, but that's still kind of like they're sort of under the thumb of authoritarian institutions like religion or a monarch, et cetera. In the case of individuals, we can talk about immaturity as simply the inability to use one's understanding without the guidance of another to determine what is best for oneself. Kids are immature. They can't use their own understanding without the guidance of another. So we have to step in sometimes. And sometimes we have to force, coerce, coax a kid to be treated. And that would be an example of non-voluntary treatment. Other times, kids maybe, as Kant says here, lack of resolution or courage to use their understanding without the guidance of another. That's okay, they're kids, but we should support that. And through the assent process, give them, the sort of resolution or at least the clarity that they need to understand what's coming. And then, moreover, this is the bonus kind of ethical obligation I would say we all have, which is to encourage the cultivation of the virtues of courage, tenacity, et cetera, that would allow kids and propel kids to find and seek out the treatment that they need for their own good when they maybe have a situation in their family that makes it difficult for them to do so. And so it's these three groups of cases that I want to share and think through with you all tonight. I think they all kind of overlap with each other, but are really grounded in these principles of respect for persons and beneficence, as Dr. Diekema described. I think that's the end of my talk. So thanks, everyone, and thank you again to the Planning Committee for the invitation to be with you all, and I look forward to the conversation.
Thank you, Dr. Sisti, very much. Excellent and comprehensive presentation. We enjoyed that very much, and we're going to get into the kind of exciting and action-packed part of the evening with involving our very, very many viewers and listeners out there who have joined us tonight and are already packing our Q&A with some really thoughtful and great questions. So we're going to go right to the bottom line. We're going to make this challenging for both of you, and we'll ask both of you to respond to this. So you've both beautifully outlined that when these difficult or contentious cases arise, there may be policy and procedural aspects within the healthcare organization that have thoughts on this. You have patient opinions. You will have parent opinions. In some cases, you will have legal opinions, both internal and external. And as you've both beautifully pointed out tonight, you will have an underlying ethical framework. So as a bottom line, at the end of the day, who wins? Who does decide, especially when all of those participants, when they have not reached a consensus, when a compromise cannot be reached, how is the decision ultimately made? Dr. Diekema, we'll start with you.
Well, so I think that's when the state decides. The state has a role called parens patriae that is to protect those who can't protect themselves when there's not somebody else there who's doing it. And so the purpose in my mind of the harm principle is first to let clinicians know when a parent seems to have crossed a line that requires involving the state. But then we have no control over what the state does. So ultimately, this is about a judge deciding whether to issue a court order or Child Protective Services deciding whether to get involved in the medical decision-making.
Dr. Sisti.
Yeah, I mean, you asked who wins. I don't think anyone wins usually, but some, there is a a consensus, hopefully, that's reached that is dissatisfying to everyone in an equal way.
Okay. We have another couple of questions that are coming in that both of you provided some great insights in your sidebars, but we're going to tackle it head on now. In this current climate that we both that we've heard both of you recognize of what can be some fairly extreme political divisiveness and emergence of some very strong opinions about parental rights and determination of their child's best interests. What are some guidelines? What are some suggestions for us as caregivers to navigate this new intensity of that conversation that can occur because of the current political landscape? And Dr. Diekema, why don't you take that first?
Well, this is largely about trust. And so, you know, I think clinicians need to focus on meriting the trust of their patients. And there are ways that are not effective. It's not helpful to tell people they're wrong, even if they are. It's not helpful to dismiss their values. And so, you know, you first have to find common ground. And the common ground here, at least in pediatric practice, is the welfare of your child. We're both interested in that. So let's focus on that. And then making your thought processes transparent, addressing parental concerns. And, you know, the honest truth is you are not going to convince everybody. I mean, somebody who comes with a purely ideologic viewpoint is probably not going to be convinced otherwise. They're paying more attention to other sources than they probably ever will with you. But the only hope we have is to enlist the trust of our families.
Yeah, and I would say also that health systems should be recognizing and supporting clinicians and reminding them that they have autonomy too, that clinicians have autonomy and they have a right to refuse and not feel bad about it and come to their supervisor and talk about it, because patients are showing up thinking that hospitals are like hotels or restaurants and basically asking for things that are totally not indicated, like ivermectin, for example, for COVID, for example. You know, I've heard cases where that's just been given because it's just easier than dealing with it. And I think that just perpetuates this autonomy run amok idea where autonomy, it's not autonomy. It's not. Autonomy is not this. This is like the Vulgate version of autonomy. This is demanding things. This is like consumerism is what it is. And so I think health systems really need to buckle down on these issues and support the clinicians for the expertise, the education they have, and the judgment, and support it. And don't take, you know, these half measures with folks who are demanding a lot just to appease them. I think that's the short-term fix that has very long-term, that's very damaging long-term.
So while we're on this topic, let's take that a little bit further, and Dominic, we'll keep you on the hot seat there, because one of our viewers tonight did put in a question to say, well, they took a little bit of offense at kind of the characterization of irresponsible or ignorant in characterizing some of the parental choice to pursue alternative therapies or to not take medical advice. And they ask a very interesting counterpoint. Where is that dividing line? At what point is that, do we decide that family is really exercising ill-informed? And does it matter, for instance, if that patient in question's parent is a physician or even a pediatrician?
I think what matters is if they understand and are sort of following evidence-based treatment guidelines and agree with them. And we have science produces knowledge, and it's not perfect, but we have a system that produces evidence that we use to operate in the world. And there's a consensus about certain things. And when an individual says they don't agree with that consensus, They've done their own whatever research online. That to me is ignorance, and that's just a term. It's a word. It's not pejorative, and so we shouldn't. We should not really take their view seriously in fact. But we should take them seriously as human beings. We should treat them with respect and figure out why they believe what they believe. But their views are wrong, and there are things that are wrong. There are things that are correct. That's the other thing that seems to be changing in our society is we're sort of in epistemic anarchy where everything is right or wrong depending on what you decide you want it to be. But there are actually good and bad choices, right and wrong choices, and parents sometimes make the wrong choices. And so clinicians are there to hopefully guide, and then maybe override parents in those scenarios.
And Doug, your thoughts on this?
Well, I would just add that, there are medical recommendations that have a very significant values component. And so you can't really tell a parent they're wrong. So, I mean, if you use the example I started with, reasonable different people are going to weigh a 3 to 5% risk differently. And I can't really say, and I have this debate in my ER all the time with parents who don't want to do a spinal tap. And most of the time I let them make that decision if I can figure out another way to keep the child safe. But I can't call them wrong because I'm placing a weight on those percentages and they are. But there are other examples, and Dominic has touched on this, where they clearly are wrong. I mean, if they're getting their information from a TV host and it's based in no scientific evidence, and I mean, it's wrong. And so there is a range here. And I think it's important for those of us who are clinicians to recognize what there really is scientific basis for and what are more values-based judgments that, can reasonably go either way.
I agree completely, Doug. I think, you got the sort of value-based issues with something where there's complicated, risk benefit outcomes, and we'll be talking about chemotherapy or something, versus like a vaccine, which is like a lot more, I think, a clearer case where you can kind of make that distinction. But yeah, I agree. It's best not to go around talking about why your patient's parents are totally wrong. And, but I think for purposes of our conversation, we kind of need to say there's going to be some really bad calls here that parents are going to make, and we need to be ready to address them.
Mm-hmm. Very good. Follow-up question for both of you, because I'm glad you alluded to that 3 to 5% rule, and then talking about the murkier areas of something like chemotherapy. So let's tackle that, because we had a couple of great questions related to that. So going back to one of our sample cases this evening about our teenager with cancer, where is that tipping point? And I can speak as a treating pediatric oncologist that I've actually had to have that conversation with legal authorities who say, well, are you talking about that 90% cure rate for Hodgkin's disease, or are you talking about a 50-50 cure rate, or are you talking about a 20 or 30% possibility of benefiting the patient? Are we down just to those statistics? Where's the tipping point in the conversation there? And we'll start with Dominic.
Yeah, I was worried you're going to start with me on that. Maybe we can go to, I do think that there's a tipping point. I don't know what it is. I mean, I think it really is just case dependent, and, the family values. You could have a family, and this is actually something I would love to hear Doug talk about, where, chemotherapy for one child could affect, the welfare of the rest of the family. It might be too, onerous. It might cause, your parents can't stop working, whatever it might be. And that's why they think it's not really worth trying. I mean, there could be social reasons for saying, we can't really go down this road, and that might be okay. But I don't really know what that sweet spot is, not being a clinician, and I'd really just want to defer to Doug.
Doug?
Yeah, and Doug doesn't know any better than you do. So there isn't really an objective answer to this question, and it's the line for chemotherapy is going to be that we would intervene is going to be a lot higher than it is for, say, a blood transfusion. And it's because it involves toxic drugs, and depending on what regimen you're talking about, it in some cases it might result in the death of a patient, depending on how aggressive it is. And the odds of survival are radically different from patient to patient. So in many ways, it's easy on the edges, right? There are very few reasonable people, I think, who would say we should let a child die if they've got a better than 75% chance of surviving with treatment. If you flip it though and go to 25%, I think, an awful lot of people would say that really ought to be the parent's choice. 25% is, it's reasonable, but it's not reasonable when we're talking about toxic drugs and side effects and a potentially miserable experience. It's that middle range where I don't think we have a good answer. It's fascinating for me to read the legal judgments, because they're clear. I think for a lot of judges, that 50% point seems to be kind of a tipping point, that you get much above that and they're like, no, the parents can't make that decision to refuse chemo. You get much below that and they're much more willing to allow parents some discretion. And but there's no way to answer this question objectively. I think it's sort of, where do reasonable people fall on the spectrum?
So we'll ease up on you both a little bit and do something a little more objective and a little more procedural. I'm sure that there are a lot of viewers like myself who are out here thinking, boy, we sure wish that we had a Dr. Sisti or a Dr. Deacom readily available to us down the hall or in the next office over at our institution. So operationally, on kind of a daily basis, sometimes the space between a clinical care team and a patient family constellation where we've really bogged down, where we can't move forward with one of these very difficult decisions, and taking it externally all the way to a CPS or to a legal, sometimes what's in that middle ground available to us are our ethics councils and our ethics consultants in our institutions. Can you both talk a little bit about their role, how that's evolved, how, what their role is in our modern healthcare settings, in this case, specifically our children's hospital? How do we go to the ethics committee, and what do those look like, and how does that work for us? And Doug, why don't we start with you?
It depends a little bit on the place you're talking about. I think more and more places today than certainly when I started have ethics consult services. And so the way that's going to look is you're going to ask for a consult, and you're going to get one or two people who come like any other consultant and weigh in on the ethical issues. Smaller places often can't have a full-time ethics person or a team, and so they still use a committee structure, and there's nothing wrong with that, quite frankly. I like the idea of getting getting a nice robust discussion from people from multiple disciplines and different ways of seeing the world. I think you are likely to come up with wiser decisions that way. In the end, I think what you want from an ethics committee or an ethics consult service is advice and guidance, but not necessarily directive. I think our role is largely to sort of hold the flashlight and help people through this the darkness, and enlighten them, but not. I think the wrong thing to expect from an ethics consultant is they're going to come in here and tell us what to do, or tell us what the right thing to do is. I personally don't think that's what we do.
Right, I agree. Ethics consultants are meant to be consultants, and they can offer recommendations. But I just thought I'd just chime in here and say they're not treatment decision-making teams. They're not teams that are designed to decide who gets treatment in, say, situations where there's scarcity. The first ethics committees were, in fact, kind of like resource allocation committees. And in fact, out in Seattle, I think was probably where the first one was, this sort of kidney dialysis machine allocation God squad, as it was called. That's not what an ethics committee is anymore, though. Like that's the when you hear ethics committee and you hear the death panels, et cetera, that's not what an ethics committee is, just for sake of the viewers. These are committees that meet in hospitals a couple times a month, enjoy donuts, and have lots of intense debate about particular cases, and often will have one or two folks who are on call who will receive a call from a clinician in the middle of the night saying, I'm struggling with this case, or it's usually on a Friday around 3:30 in the afternoon when you're getting ready to leave, that you get that call. And it's like, this parent or this family member is struggling to make a decision about their loved one, and could you come down and talk to them? And essentially you kind of shift into a kind of almost, at least when I was doing clinical ethics, it felt almost like pastoral care, even though I have no pastoral. It was just sort of like listening and allowing the patient to, or the surrogate, whoever it is, to just kind of vent. Sometimes that's what all it takes. Maybe in a meeting with the rest of the clinical team and another consultant, the family members can get all their values out and talk through things. Maybe nothing changes, but oftentimes that communication allows for the process to become unblocked. If it was blocked in some way, it just unblocks it. So there's nothing really magical about ethics committees, but they do serve a very important function. And a good clinical ethicist can help resolve cases before they have to go out to a court or to a judge. It's something you really want to, I think, avoid at all costs, is getting the judicial system involved.
Great. A really wonderfully thoughtful question that both of you touched on indirectly, and that we'd like to expand a little bit more. In these very difficult decision-making situations and processes, how does unmanaged pain, unmanaged suffering, symptoms that are not under control, how do those medical impacts also impact the ability to engage the child or teen in this decision-making process? And we'll start with Doug.
Well, I think if you're talking about the capacity of the patient to be involved in making decisions, I wouldn't say pain disqualifies somebody, but it does impact your capacity. I mean, I can say that from personal experience, that if I'm, in an emergency department with a serious injury, I would prefer that somebody else be making the decisions. And I just don't, feel like I'm in a place to do that. But, and other people may feel differently about that. So it clearly impacts. I'm not entirely sure, what I'm missing in terms of the question that was being asked, but
I think a little bit more information just in terms of the timing, the ability of the various participants, even the distractions that are present in the acuity of a medical situation, and how that colors the decision making at that moment, and how we work through that.
Well, and that
I'll
can,
try.
yeah. I mean, I'll just say it. The medical environment is not optimal for making decisions, particularly if it's not a chronic condition, if it's an acute situation. I mean, people are stressed and the environment is noisy and things are happening fast and it's overwhelming. And so, yes, it's very difficult. And that part of our job is to help people walk through these decisions in a reasonable way.
Dominic?
I would just add to that, and this is a very famous bioethics case, not a child, but the case of Dax Cowart, I think, is very instructive in terms of how pain interacts with capacity, at least in adults in this one particular case. And I use it when I teach to just kind of describe this scenario where a person's in shock and in pain and asking to be allowed to die. Actually wanted the farmer, if you remember the case, if folks remember this case, he asked the farmer to bring him a gun at the very beginning because he was in such shock and pain. He wanted to kill himself right there. And the farmer made the right, I think, decision and said, no, sorry, it was too soon. Likewise, the doctors early on in Dax's case, Dax Cowart was a man who was severely burned over his entire body in an explosion in the 1970s. And so folks who are watching, if you haven't heard of this case, you can Google Dax Cowart. his pain was like torture. You know, his entire body was raw, and he was being dipped in these baths to treat the burn, to treat, you know, infection and hopefully improve the healing. Day after day, week after week, month after month, he was in awful pain. But I think that pain gave him more capacity, actually, after a certain point. It gave him the insight into, like, this is not the quality of life I want. This is not what I want. This is torture. Early on, I would say he just didn't have capacity. It was too soon. But, you know, and I don't know what that time is. I don't know when that moment is where you stop, you know, using, best interest and just go with pure autonomy, because he was capacitated. But the pain was seen as the thing that made him incapacitated, and that just wasn't the case after a certain point. So with kids, it's more complicated. But it could be the case that we want to start taking their pain seriously, and not thinking it undermines their ability to make decisions, but rather it's informative of their values.
Very interesting perspective. A couple of folks, and this was one of my, actually I scribbled it down. I don't know which of you said it, but one of my take home messages that I loved tonight, one of you said that assent is actually training wheel consent. And I love that. I'm going to remember that. So expand on that a little bit. I think throughout children's hospitals, certainly, and folks in pediatrics are really trying to be smarter and better about incorporating assent in that process, recognizing the emerging autonomy, recognizing the emerging and developing decision-making potential of the kids who are kind of on that cusp in that 13, 14, 15 age range. What are your recommendations for doing a better job of more regularly, not only getting the necessary consent, but really bringing assent into the conversation more regularly with those kids at that age? Doug?
Well, I think we misuse the term assent sometimes. Technically, assent means the child gets to decide. I mean, you know, at least in the research environment, if assent is required, it's the active affirmative agreement of the child, and that carries the day. So I think it would be helpful if we use more precise language. There are many situations where we should be engaging children. We should be asking for their opinions, but we have to be very careful, particularly with the younger ones, about making them think they have a decision when they don't. And so, you know, there may be times where they do. I mean, there are situations, you know, in my ER where I will not do something without the child's assent. They're usually low. They're usually situations where there's not a lot at stake. You know, maybe we're thinking about doing a test and the parents would kind of like it done, but it's not clear to me it's really going to add significantly to the care of the child in an important way, and the child just really doesn't want their blood drawn. That may be a case where I just say to the parents without, you know, them on board, we're not going to do this. But most of the time, I'm not going to give the child that kind of authority. And so I do want to know what they think, and I'll give them choices where they can have them. So which hand would you like us to put the IV in? And what color popsicle would you like afterwards? And, you know, so that they have some control in the situation. But a lot of the time, we're not really giving them the authority to make decisions.
Sure. Dominic?
Yeah, and I think, you know, the idea that assent can be kind of training for consent presupposes that the consent process works the way it should in our society, in our healthcare system, which it doesn't. It's like a form, right? And that's not what informed consent is. It's, you know, it's not just a sheet of paper that patients are supposed to just sign off on and move on. It's meant to be a conversation. One of my colleagues, you know, says that if you're not talking 50% of the time as the clinician, at, you know, no more, less than 50%, you're not doing consent right. It should be a conversation. It should be something where the patient is invested in some way in understanding what's about to happen to them. And if they're not, then something might be off. They might say, I don't want to know, and that's fine. And they can relinquish their, you know, they can delegate somebody. But for the most part, it should really be a conversation. And I think that's kind of the point of the Ascent too, is just to have a conversation where you're going to bring in the values of the child in a way that matters to what's going to happen next. Now, it might not be Ascent. We might want to just call it shared decision making or something, right? Where you're kind of giving the minor a share in some sense, or a voice that's maybe non-determinative, but is still important. That might be what we call it. Ascent is sort of the colloquialism I'm using. But yeah, I think that the idea is that we want to gear up kids to be advocates for themselves and engage in a conversation with their clinicians and raise questions and not feel worried about, asking questions or being, kind of passive, but rather being an active participant. And that's how we get them geared up for adult medicine.
A couple of our participants this evening really appreciated the reminders of kind of the neurobehavioral, neurodevelopmental aspects that are at play here, especially with the developing brain, with the impulsivity, with some of the challenges we have. For both of you, how do you, knowing that hardwiring in adolescence and knowing those challenges in brain development and in full understanding and working through the impulsivity, how do you as practitioners actually incorporate that? How do you work with that knowledge and bring that to the bedside in your work in engaging adolescents in their healthcare decisions? Doug?
Well, to do it, you need to recognize where their prefrontal cortex is going to have the hardest time engaging. So you start with the recognition that at least, from 14 and up, they have a pretty good ability to make reasonable decisions. But the situational context is really important. And they're much better at cool, what some people call cool processing than hot processing, when emotions are running high, when there's pressure, when their friends are pushing them to do something or their parents are pushing them to do something. Not an optimal opportunity for them to make good decisions. When there's the opportunity for a big reward, a rush of dopamine, not a great opportunity to make reasonable decisions. But if you think about a medical situation, the acuity has passed. They have had time to sort of get over the overwhelming anxiety producing, diagnostic phase and start having reasonable conversations about what's next. And they're not bumping heads with people like their parents just to bump heads. That's when engaging them is much easier. The best parenting technique for parents of adolescents is when they're having a complete meltdown about something you just told them they can't do. The worst thing you can do is argue with them at that point. They are not in a rational space. Just let them go to their room and finish the tantrum. Half of the time they'll come out of their room and they'll solve the problem. But you got to give them the space to do that. You've got to get them back in a space where they can engage their rational brain, and heat of the moment is not the time to do it.
Some sage parenting advice beyond even the scope of. I wish I had that advice earlier today. My kids had off from school, and we had one of those, Doug, around shopping.
Oh,
my 11-year-old, and I took the bait.
Dominic, some additional comments on that, on how knowing the hardwiring we're up against, how does that inform your practice?
Well, first of all, I'm surprised that I'm here today, knowing what I now know about my teenage brain, and I did. Oh, excuse me. But I will say that my kids are teaching me a lot about this, and it is the case. I think that we want to be just really you talk about trauma informed treatment. We need to be neurologically sort of. I love the fake disorder that Doug made up, but we need to be informed about the circuitry of these humans among us that seems to be a little bit off at times. And not to think it's so hard because it seems voluntary, right? It seems like volitional when they act out or act in a certain way, but it's almost like that's a mask of maturity over this just automatic or autonomic just behavior, and that's kind of what I'm starting to figure out. I'm not a clinician again. I'm just reflecting on parenting stuff here. So
sounds good. In honoring everyone's great time commitment and incredible contributions tonight, we're going to wrap up in a little bit. I'm going to warn both of you that we want some closing thoughts and comments, anything that you didn't get in the formal presentation, anything that the Q&A has prompted, any words of wisdom that you're going to part with. But right before we give you both the chance to do that, one of our viewers, Doug, has asked for what was the ultimate solution for your two cases that you presented? What were the outcomes?
I apologize for not providing those. So on Tage, Child Protective Services came in, the police were called, the police actually physically restrained his mother while a spinal tap was done, which is not the optimal way to do this, unfortunately. So, it's hard for me to judge, not having been there that night, but a gentler approach is one we would always prefer if possible. Daniel Hauser, his mother, his case went to a judge who actually had Daniel in the courtroom and very easily came to the decision that he was not making a rational decision. So was unwilling to call him a mature minor, told his mother that they were going to have to report to the oncology clinic, and if their work demonstrated that his cancer was not in complete remission, he would need further treatment. At which point his mother put him in the car and started driving to Mexico. And fortunately turned around at some point. And I think, one of the wiser people in that scenario was the local district attorney, who went on the news and promised her that if she returned with her son, he would not press charges, to not make this a punitive situation, but one that was really about her son's health. And so my assumption is he received treatment, and probably without restraint, because I know I had a conversation with their ethics consultant about when he came back with what should they do about, if he really did resist the way he said he would. And I'm assuming he did not and got treated.
Aspects that are heartbreaking, but also maybe heartwarming in some ways, when those caring individuals come together to try to do the right thing and to try to reach the right answers for those very, very difficult and challenging ethical situations. So some closing wisdom and remarks. Doug, since you have the floor, why don't we start with you?
I'm a big fan of a good dose of humility in these cases. Recognizing that a lot of what we do in the medical profession has a healthy dose of values, and those may differ from those of our patients. And there is a line which I've tried to draw, where I do think we need to get the state involved, and the state will not always do what we want them to, which we have to deal with. But I do think we need the humility to recognize that we don't have all the answers. Even our database answers come with percentages attached to them. And we need to be aware of that just because we feel strongly about something doesn't necessarily mean that it's right for everybody.
Beautifully said. Thank you. Dominic.
So I just would reemphasize this idea that we should encourage, empower, and cultivate young adults, adolescents, to take ownership of their healthcare, and we should advocate for policies that allow adolescents to do just that. I think that's the positive argument for all of this. It's about enhancing and empowering kids, and we need to do more of that. We need to have education programs everywhere that give kids, the truth about reproductive health, about vaccination, et cetera. I feel the kids, I know this is such a cliche, but they give me hope, because some of these parents they're worrying me. Their kids, on the other hand, the folks that Vax Teen, those folks, amazing. so we need to empower the quiet kids that aren't sure about what they can do, what they should do. We got to find those kids, empower them, and give them, enhance their autonomy, while we're trying to protect and treat kids that maybe have incapacities and are less mature. And so doing both of those things, I think it's equally important. Protect the vulnerable, but also empower the folks that have that capacity to be, self-determining quasi-adults.
Well, I will take the moderator's privilege and say that I think you both chose absolutely perfect exclamation points to complete a really wonderful evening and some incredible insights. We thank you both for your expertise. We thank you for the generosity of your time in participating so meaningfully in this great gathering this evening. And I know that I speak on behalf of many viewers out there who had joined us tonight. Hopefully a large number of them, we got to their good points and questions in expressing our heartfelt gratitude for your time and expertise that you've shared so generously with us this evening. And I'm delighted now to turn it back over to Lola.
Well, thanks so much, Dr. Fauner, Dr. DeCaman, Dr. Sisti, for such a wonderful and thought-provoking presentation. I share Dr. Fauner's sentiments. You were the right speakers on this topic, and we've all learned very much from both of you, and from Dr. Fauner, your moderation of the Q&A and guiding the questions from the audience. So thanks so much, I think, for an enlightening evening. We also want to continue, of course, to thank the Colloquy Committee for their preparation in this evening. Dr. Jeff Burns and myself thank the committee for their hard work in making this happen. There'll be another colloquy. We do these biannually coming up in March, so stay tuned for that on the Colloquy website. I also want to thank our principal sponsors, Grand Valley State University and Spectrum Health, and our major sponsor, Trinity Health, once again, for their support of this event this evening.